Now, with the multiple provisional diagnosis, our mind is as blurred as the disc. And to clarify this, we have someone with a very strong academic and clinical background in neurophthal as well as medical retina. Introducing Dr. Natasha Radhakrishnan for her talk.
Thank you, Dr. Deepa, for this opportunity. Good morning to all. So we can now see how imaging modalities will help in clarifying a blurred disc. So we have already gone through the causes, so I'm not going into that. So an approach to a case of disc edema, we said history. So the symptoms of raised ICP, systemic symptoms, then assess visual function, ocular examination, and then we come to the ancillary testing, which is ocular imaging. So you can have a visual field that helps you, OCT of the disc and the macula, fundus autofluorescence, ultrasound, photography, and fluorescein angiogram or the ICG angiography. The most important thing that we need to distinguish in our clinic usually is to distinguish between pseudopapilledema and papilledema. So for that, you have to first look at the refractive error of the patient. Is the patient hypermetropic, which suggests that the disc is just small and crowded, or is it like a optic disc drusen? Why to differentiate? And how to differentiate, because why to differentiate is because you will send the patient on a wild goose chase to the neurologist and everywhere else, end up getting an LP and everything, when the patient actually had something that you could have ruled out in your OPD before you sent. So that is the importance of differentiating these conditions. And what are the things that give you the signs and symptoms, of course, then the refraction, then clinical other clinical hints, and like a lumpy bumpy appearance in the case of an optic disc drusen, which is not a uniform enlargement of the or rising of the optic disc. And the things that help us in this are the ultrasound, the fields, and the FFA. The fundus autofluorescence is a very important tool to distinguish optic disc drusen from pseudopapilledema. So the autofluorescence normally shows a dark optic disc because the absence of the RPE and lipofuscin. However, in optic disc drusen, there is fluorophores that are detected on the autofluorescence. So this is a disc that actually looks like a very early papilledema, and but on autofluorescence you can see the buried drusen on both sides. The B scan is another important investigation. It can help us in drusen, which Dr. Sindhu had shown, because it will have a hyperreflectivity there with like a extra shadowing. But another thing that it helps us in differentiating the drusen. Optic disc drusen. Another thing that it helps us in differentiating is the T sign that comes in posterior scleritis. Along with the disc edema, you would be able to see the T sign, and also you can see the elevated disc in the center. So both ways it helps us in differentiating. Now, when will you do a fluorescein? So, fluorescein angiogram helps you in looking at the blood flow at the disc. So, in cases of pseudopapilledema and papilledema, if you absolutely cannot differentiate that it looks blurred and all other sides, there's no hypermetropia, you're not able to figure out if it is papilledema or pseudopapilledema, then a fluorescein angiogram will help you, because even in early papilledema, you will get some leakage of the disc, which will not be there if it is a pseudopapilledema, if it is just a crowded disc appearance. So that is one way. And you may also pick up choroidal folds which are not seen clinically. In AION, fluorescein helps us because it will, in arteritic, you will get a significant increase in the arm retina time. The early phase sectoral filling defect can be very clearly seen, and late optic disc leakage will be seen. In arteritic, you will find severe choroidal filling defect also. So this is an arteritic AION where you can see that the choroidal filling is also very patchy. And this is a simple non-arteritic AION on the left side, and this is the optic nerve head showing the increased values in the RNFL, and this is the altitudinal field defect, and here you can see the filling defect, sorry, that should be inferior, superior filling defect here, and then the late leakage. The diabetic papillopathy, this is again an innocuous condition, it sort of signifies that the patient is progressing into PDR, but it really does not require any intervention. So here you will get prominent disc telangiectasias, and you can confuse it with NVD. And the differentiation, one differentiation from other causes is that the vision will not be affected. If the macula is not affected, there will be no decrease in vision. And how will you differentiate it from NVD is to look for global ischemia in the FFA. If it is just a diabetic papillopathy, there will be disc leakage, but the CNP areas will not be too much. If you get CNP areas, a lot of CNP areas along with disc leakage, even if you think that it is diabetic papillopathy, better to treat it as an NVD. So this is how the telangiectatic vessels look in a diabetic papillopathy. The LHON, you can get peripapillary telangiectasias with no leakage, no significant leakage on FFA. Optic disc granulomas, you can get a late phase hyperfluorescence. Inflammatory conditions, you will get diffuse optic. So you cannot differentiate papillitis from papilledema with a fluorescent angiogram. Both will leak just the same. AION also, if you do an FA and you don't concentrate on the initial phases, you may not be able to differentiate whether it is an optic neuritis or an AION. The initial sectoral filling defect has to be picked up if you want to differentiate that. And in pseudopapilledema, of course, none of these features will be seen. VKH, along with the disc leak, you can look for the pinpoint leakages that tell you that the choroid RP complex is now leaking. In OCT, how does it help? Will it help if you want to differentiate early papilledema from a crowded disc? No, because early papilledema also values will be lower part of the increased from normal, and in crowded disc also it will be in the lower part of the increased from normal, which means it will be white. But if you are in severe papilledema, and if you want to differentiate very elevated disc, then you will find that the values in papilledema compared to optic neuritis are far more than optic neuritis. Just like we say the disc edema is far more in papilledema, the measurement is also just the same. So the importance of an optic disc RNFL values come in monitoring more than diagnosis. So one is quantifying the disc edema in the beginning, and then as you can progression of the disc edema or going into optic atrophy, you can monitor using your optic disc RNFL. So in conclusion, imaging is an integral part of investigating a blurred disc. Used and interpreted alone and combined, they help us to reach a reasonable diagnosis. But it's important to know what and when to use and the findings in each condition if you want to differentiate the conditions. I have not gone into MRI, and I think that will be covered in the optic neuritis topic. I think we have some time left. If I will be going for the next session, so if anybody wants to ask any doubts, I'll be happy to answer.
Madam, to come to a conclusion is usually difficult. We have to send for imaging and all that. So is it always advisable to start IV steroids?
For optic neuritis?
No, disc edema, whether it is optic neuritis, whether it is AION, there's a confusion.
No, absolutely not, because you're doing the patient a disfavor if you're going to start steroid, systemic steroid, without reaching a conclusion whether it is AION or optic neuritis. Now, why do I say this? Because if you are if you're thinking it is AION, the patient's got AION because of hypertension and diabetes. Now, you're going to give him steroids, which is going to worsen his hypertension and diabetes and doesn't serve any purpose. Secondly, if it is an optic neuritis, you have no business giving systemic steroid in the oral form. It should be given IVMP. Patients in the ONTT who were treated with oral steroids had a worse visual outcome than patients who were treated with, not visual outcome, but the occurrence of MS in that group was much higher than the patients who were treated with IVMP. So both ways you're doing the patient a disfavor by starting systemic steroid. So how can you differentiate? All these things will help you differentiate. Now, if you absolutely cannot differentiate with this, then you go in for a VEP and and an MRI. And the VEP will show prolonged latency in optic neuritis. In AION, only a decreased amplitude, no difference in latency. And in an MRI, you will find the demyelination plaques if it is an optic neuritis. So those ways also you can differentiate. So I would just observe and not start IVMP or systemic steroid.
Thank you, because there's always a tendency to start injection DEXA and all. That's why.
No.
Thank you, ma'am.
Correct.
That's the only emergency in which you want to give IVMP urgently because you want to save the other eye. Optic neuritis is not a die-hard disease. There is no harm in doing the MRI and confirming that there is no intracranial pathology. Because sometimes you can have infective conditions along with optic neuritis. It could be an infective condition which is producing optic neuritis. But you need to take care of the infective condition also. So pushing in IV steroids is not the ideal thing without the exact diagnosis. So only if you strongly suspect an arthritic ION, which is an elderly patient who comes to you with very poor vision and may or may not have signs and symptoms of jaw claudication, but what you can do is you can do an ESR CRP platelets in your OPD, get that done, and if you clinically feel the temporal artery is not palpable or pulsations are very feeble, and get a physician's opinion about whether the patient is fit to get an IVMP. And that's the only time you're doing a favor to the patient by preventing the next eye getting the attack. You cannot save that eye because that eye is already gone. It's a pallid disc edema. That's the only true medical emergency. I agree with Natasha that you don't have to immediately start IV steroids in optic neuritis, because optic neuritis, if you see the course, it reaches a plateau and then it improves. That's the normal, typical optic neuritis. So, but you have some time. You get the proper investigations done and then only start. And in AION, the studies have shown that steroids do not really help in the final outcome. You are actually going to do more harm. I had one patient whom I didn't start treatment because it was AION. Patient went to a neurologist. He started the patient on IVMP because neurologists always think in terms of optic neuritis. Patient developed a myocardial infarction. And because his everything shot up, he developed a myocardial infarction. He had to undergo angioplasty, so many things, which was totally avoidable if you can make that.
Yeah, I have had the same experience. IVMP given by the neurologist, and the patient admitted with, he had a COPD that worsened, and then he was admitted in the ICU. And they came back and said, "Madam, vititanu idellam sambhavichadu."
So how long can we wait before for that? Supposing the investigation takes a long time, maybe 1 week, is it okay that we wait till we get the reports?
1 week should be okay, because it does reach it will increase for some time and then it will plateau out. So depends on when the patient reached you. And after that it's going to improve if it is a demyelinating optic neuritis. The other point is also very important, because your optic neuritis may not be demyelinating at all. It may be because of pansinusitis, or it may be because of some other infiltrative thing inside the orbit. So that also needs to come out before you push in your IVMP.
And
The only investigation I would definitely immediately do, apart from arthritic in an optic neuritis AION scenario, is MRI.
Yeah.
MRI is the only really thing. All other serology, everything can wait. Okay, MRI, you get it done. You should, even if you don't see plaques, it does not mean it's not optic neuritis. It could be an isolated optic neuritis. It need not be always demyelinating optic. In India, we don't see so much of MS. We see more of MOG and other. Even it could be infective condition producing an immune optic neuritis. So you don't see much on MRI, but optic neuritis is a clinical diagnosis. You go by your instincts, and then you do serology, but MRI is the most important investigation you have to do. You will get the results in 1 or 2 days, right? At least the next day you can call up the radiologist.
And if the patient comes late to you, presents late, maybe 1 month or 1.5 months, is there any role in giving IVMP then?
You look at the disc.
Yeah.
You look at the disc. If the patient has completely improved per se,
No. The vision is still
bad.
see-
So that's not a very typical optic neuritis. Like, then you have to think, but you will still do all the investigations. And if the patient is symptomatic, and if you're showing like you're getting a prolonged latency on VP, MRI may or may not be contributory. But patient is in that age group, young patient, you can give. We can do a flash VP.
Thank you, Dr. Natasha.